We have our next speaker, Dr. Rengaraj Venkatesh from Arvind Eye Hospital. He is going to talk on MIGS in developing nations like India. How are we different from the developed world, and where do we stand in terms of results and economics?
Thank you, Amit. Very detailed topic. So, well, but I'll try to finish in next 8 minutes. So, you all know the problem of glaucoma, the burden. I would say now it's going to almost double in 2040. Now we've already crossed 2020, but it's more so in India. This number may be staggering by 2040. But what we understand now is from most of the tertiary care centers, we see that more and more of mild to moderate we have started seeing referral from primary and secondary care. Almost 36% had mild to moderate. Similar work we did a couple of years back in Pondi, just after COVID, to see 60% had mild to moderate glaucoma on presentation, which with the vertical cup disc ratio of 0.6 in the better eye and 0.7 in the worse eye. And if they come little advanced, mostly they were older and with the low educational levels. And we all know the financial burden. I don't have to talk about it. Most of them are dependent. And if you see in the low income group, 26% of their monthly income was on glaucoma treatment in many times. Same way, this expenditure, kind of change from high income, just 0.3% to somewhere 123% for low income. And more so, there is a lot of other expenditures of travel, stay, and loss of wages when they come back for follow-up every 3-6 months to us. So many patients are now having a salt and pepper like me. Now you're seeing glaucoma at a much middle age now, coexisting cataracts, definitely a big financial burden which you see either with medications or even laser if they have some good results for a couple of years. So I'm sure we all know that glaucoma is a surgical disease, but over a year we have been moving from traps and tubes because of a lot of these issues, long recovery, a lot of challenges post-operatively, and it significantly impacts the quality of life, which is changing now with the new generation. They want a good quality of life. That is where MIGS comes. We know MIGS is there for a couple of decades, some of the devices for more than 10-15 years, and we are seeing some good results, and that's why we are saying it's highly safe. It's kind of reasonably good IOP lowering effect. And also we see rapid recovery, like cataract patient bouncing back to the regular job. This we are seeing for the last 3-4 years. And that's where I'm able to confidently say that you can now do for most of your mild to moderate ocular hypertensions, either open angle or even angle closure like Sirisha highlighted. And definitely there are some of the relative indications. Even in advanced glaucoma, if they are older age, life expectancy is less, they have a lot of comorbidities, you can think of doing some of these procedures. And you all know I'm just talking about things which are just available in this country now. Zen may not be available, but it may be. But enhancing the Schlemm's canal will be the key, how we are going to enhance. So there are a lot of devices and also techniques which does not depend on devices. And you have something which is destructive for kind of glaucomas which are not manageable with all this. So whenever we are talking about MIGS, at least in the developing world setting like here and several other countries, it's either resting. Where you want to rest it, it's usually the devices, whereas we call it as ripping, where you excise or incise your trabecular meshwork for a better outflow. So resting, if you see, is kind of cost prohibitive. We all understand that we have some resting devices. We have devices coming up in the next few years in the market, but definitely they are cost prohibitive. It's not that they are not very effective. We are seeing some good effect in Indian eyes slowly in the results which are coming up. But if you see this data, where there is for every millimeter of IOP reduction, if you compare between trap, this was a study done in Middle East, but it equally holds good. Somewhere the difference is almost 10 times higher. So when we talk about ripping techniques, these are all the techniques which are there with us, which are really some of the viable options in front of us. But the point is, there are definitely, we have devices especially which are not available, and of course greater incidence of angle closures and advanced glaucomas we have to keep in mind. But adopting MIGS is another challenge. Some devices are cost prohibitive, some definitely we need more training, and also No, we need better infrastructure, microscopes which are good, where you can have positioning and all that to do comfortably these procedures. So it's not a big challenge, but it is a challenge in some places, but we'll have to keep working on it. So whenever we are trying to navigate through the economics, I think one technique which comes in my mind is the GATT, which all we learned from Davinder Grover. My colleague Swati is sitting here. I mean, she trained some of the colleagues in Arvind, and now most of them comfortably do this 360-degree trabeculectomy using a very less expensive phyoproline suture. It really helps in advanced glaucomas, and that's what my good friend and colleague Devendra had published. There is significant IOP reduction in 6 months when you compare phaco GAT and GAT. If you see the GAT, the IOP is slightly higher, but there is a very good reduction and when you combine it with cataract, it is really good. And I'm sure the results, we have to work on MIGS results on long term, 2 years, 3 years, but whatever short term results is very promising. This is some study on advanced glaucomas, especially advanced pigmentary glaucoma. They had both GAT and the TRAP group. And if you see, there was significant IOP reduction in both the groups and also significant glaucoma medication reduction in both the groups. So it really works in advanced glaucomas. Again, when you want to navigate, I think this technique is brilliant. You just bend your 25 gauge needle and you can start doing a nice incision of the trabecular meshwork. So this works, and we have a lot of good studies, again from the AIMS team, 32 eyes of 32 patients. They followed up to 12 months and found a significant IOP reduction. And if you see the success, again, more than 20% reduction was achieved in almost 62%, and the overall success you can see in 87%. But we need more eyes and longer periods of study. But one thing which we all like and admire is this hook. I have no financial interest, expensive hook, and I saw few trades having this at a low cost. I don't know how it works, so I can't comment on that still. But the Tanito hook is $5,000. But the best thing is it is reusable, it's sustainable, it goes into your set, it can go to your flash autoclave, come back, and you can continue to do high volume with these hooks. Again, a brilliant study from my colleague Devendra, where he saw the phaco trabeculectomy group and phaco group. You can see there's a significant reduction in the phaco Tanito group. Sorry, not trabeculectomy, phaco Tanito group. And then the medications also, there was a reduction in the anti-glaucoma medications. So we have some good results coming from the other parts of the India also, like how you see here, this is 30 eyes of 30 patients, where again there was a significant IOP drop, and they all had visual outcomes when you are combining with cataract surgery. So when you see the mixed device market, I'm sure you're going to see in quick in India. There are new devices coming up, and there are several devices which is already in the market which will come to India. And if you see, this is a global CAGR, cumulative annual growth. There is significant increase in the devices and the usage of these devices because the results are getting better and the complications are reducing. But this is a thing which we have to direct. So for that, we need long-term randomized control trial, looking at success rates. Like what Sirisha said, maybe 2 years, 3 years, 4 years down the line, we'll have to see some of these results. Definitely, we have to improve some of the infrastructure and training for MIGS. Otherwise, we may have a lot of devices in different places of the eye. Definitely better understanding now who will, because we can tailor the surgery now. Who needs a trap, who needs a tube, who needs a MIGS, and all that is very important, that understanding. And finally, subsidizing, insurance or even government subsidy to it, or through the PMJ scheme. We'll have to see what really helps some of our mild to moderate so that we can surgically manage them in a better way. Thank you.